Honorable chairpersons, dear colleagues, it's nice to be on RAB and to participate in this nice and well-organized congress. Present you the case of a 63-year-old female. She was presented to our emergency department due to prolonged episode of chest pain. The first time in her life she had chest pain at rest, and it was lasting for several hours. Past 2 years before admission to emergency department, occasionally she had episodes of chest pain and shortness of breath. Lately, more often, which started to disabling her regular activity. In last 3 days before admission to the emergency department, she had several black stools, and 5 days before admission, she was vomiting for 2 times without any signs of blood. 7 days before admission, she started with polypill therapy, atorvastatin, perindopril, amlodipine, and like usually patients think, she thought it was a side effect of the therapy. During that period, she had lack of appetite, but no other symptoms until the day of presentation in emergency department. From previous medical history, we can see that she was suffering from moderate aortic stenosis. That last echo was made several years ago. Arterial hypertension, hyperlipidemia. She was a smoker for many years, and she was taking current therapy with aspirin in that therapy. Colleagues in emergency department in physical exam noticed that she was pale, sweaty, mildly dyspnoic, respiratory rate 24 in minute, blood pressure 90/50, with 94% oxygenation, pulse rate 90 per minute. Auscultatory, she had bilateral pulmonary crackles with heart murmur of aortic stenosis. On digital rectal exam, they could see traces of melena. So they made routine laboratory exams in which we found pathological hemoglobin and platelet count as a moderate anemia, then elevated troponin T and NT-proBNP levels. On chest X-ray, we could find signs of acute heart failure. On orientational echo, severe aortic stenosis, and on ECG we see regular sinus rhythm with left ventricular hypertrophy and strain. So colleagues started with initial treatment in emergency department with rapid infusion of crystalloids. They gave her about 1500 milliliters in less than 2 hours, and then they gave her 80 milligram bolus of pantoprazole and metoclopramide 5 milligrams. During the diagnostic process and during the treatment, she suddenly became hypotensive, dyspnoic, orthopnoic. So they started with additional treatment. They started with norepinephrine infusion and started with non-invasive ventilation. Shortly after that, we admitted patient to our intensive care unit, and we continued with non-invasive ventilation with full mask. We started with invasive hemodynamic monitoring. We gave her immediately 2 units of deplasmatized erythrocytes and 1 unit next morning. We continued with crystalloid solution infusions. We were keeping her in positive balance, and we continued with infusion of pantoprazole, norepinephrine. In the beginning, we gave her morphine as a slightly sedative, and we start with intermittent every 4 to 6 hours furosemide, 40 milligrams, and we called gastroenterologist, who postponed upper digestive tract endoscopy until hemodynamic and respiratory stabilization. I have to advocate our colleagues on gastroenterology. They are in different hospitals, and this is across the city, so it's not, sometimes for them it's not easy to come and to do it, especially in this kind of patients. So, early stage of clinical course went good. She was hemodynamic and respiratory sufficient. After several hours of vasopressor, diuretic, and non-invasive support, but not completely stabilized. She was still symptomatic at bed rest and orthopnoic. We managed corrections of laboratory parameters, renal function, liver function, and lactate levels were on normal range. So on the day 2, we ceased non-invasive ventilatory support, and she was respiratory sufficient with mask oxygenation up to 5 liters per minute. And we repeated echo, this time detailed echo. It works, but okay. So we find the elements and confirmed diagnosis of severe aortic stenosis with calcification of aortic valve. So we presented our patient to hospital heart team and tried to find a decision what to do next. Key points are symptomatic at bed rest, recent gastrointestinal bleeding, and resistant acute heart failure. So decision of heart team was that we proceed with endovascular treatment with TAVI procedure. Prior to TAVI procedure, we did no other diagnostic imaging, and size of prosthesis was selected by echo-derived dimensions of aortic valve anatomy. And we planned that intervention for next day, on day 3. So, standard procedure in our hospital, we go with conscious analgesic sedation, local anesthesia in both groins, implantation of temporary transvenous pacemaker. We start with heparin in the beginning of procedure. We gave antibiotic prophylaxis in regimen 0-4-24 hours. First we did balloon valvuloplasty, and after that implantation of Medtronic evolutar prosthesis, and post-dilatation you will see later in movies why we decide that. So arterial puncture sites or both groins were closed with 2-pair closed prostyle vascular closure device, and on the other side angioseal vascular closure site. Procedure started with coronary angiography, and we did not find any significant coronary artery disease. We made a distal and proximal aortography to see exactly anatomy, puncture sites, and correct or make another measurements. And after that we went to balloon valvuloplasty and to implantation of Medtronic valve. This is point of no recapture. And then after the implantation of the valve, we did not succeed complete expansion, so we did post-dilatation with the same balloon, and well, it was optimal result. So we checked that on echo. We have good result on the echo, and she was, after procedure, received back to intensive care unit. She was on oxygen therapy for next 24 hours. Pantoprazole, enoxaparin as a thromboprophylaxis. We reduced the dose of furosemide. We gave her clopidogrel without loading dose, and later we started with beta blocker and ACE inhibitor therapy. After complete stabilization and regression of acute heart failure symptoms, she was discharged from intensive care unit to regular cardiology ward, and on day 7 she was discharged from hospital. If somebody was asking what happened with upper digestive bleeding, we got answer 5 days after dischargement. Colleagues performed gastroscopy, and they found 2 gastric ulcers who were already in forest 3 stage. So they prescribed her pantoprazole 2 times 40 milligrams for next 4 weeks, and after that lifelong, practically 40 milligrams. Last follow-up was a month ago. She was completely without any symptoms. It's about 2 years after the implantation of the valve. She is regularly taking prescribed therapy. She is a school teacher and regularly performs her daily business and private obligations practically without any symptom. So, at the end, my conclusion is that urgent TAVI procedure is life-saving and feasible medical intervention in hemodynamically and clinically unstable patient when performed by experienced center. Urgent TAVI scenario due to clinical instability of the patient. The size of the prosthesis can be determined by echo-derived dimensions of aortic valve, and this is procedure which needs teamwork. Everybody is important, no matter interventional cardiologist, advanced cardiac imaging, or intensive cardiac care professional.